Why some people decline and others don't. Two older adults can have the same amyloid, the same MRI findings, yet one stays sharp and the other declines. Dr. Acker studies the network-level rules of resilience that explain why. Welcome back to Alzheimer's Breakthrough with Dr. Josh. Today, I have the pleasure of speaking with Dr. Leah Acker, a physician scientist whose work sits at the frontiers of cognitive aging, brain variability, and network neuroscience. Dr. Acker completed her PhD through the HST Harvard-MIT Health Sciences and Technology program, where she focused on neural control systems and human cognition. She is now an anesthesiologist and faculty scientist, assistant professor at Duke University, studying intra-individual variability in cognitive performance, network responses under cognitive challenge, resilience versus vulnerability in the aging brain, predictive modeling of cognitive decline, and individualized neurocognitive trajectories. Her work moves us closer to a world where we can forecast cognitive decline years in advance and intervene. Resting state scans can lie, but when you put the brain under cognitive stress, its weaknesses show themselves years before cognitive decline. Dr. Acker, my next guest, is one of the scientists proving this. Dr. Leah Acker, thank you so much for joining my podcast, Alzheimer's Breakthrough. It's such a pleasure meeting you, and the story of how we're talking today, I think it's worthy of bringing up that we both went to the same Harvard-MIT program. You got a PhD there. I got a medical degree there. I was there many years before you, but the reason we're talking now is the HST Harvard-MIT program just celebrated its 55th anniversary. You were there too, right?
Yeah. I was, Dr. Josh. Thank you for having me. And yes, it's such a pleasure to reconnect with HST alumni and other folks in this community.
Yeah, it is. And what I loved about it was the understanding that we're different than I think almost every other program I've ever heard of, because our focus is problem solving, and basically from Dr. Irving London, who founded the society, who's a problem solver and wasn't afraid to do more than one thing and break boundaries for the sake of fixing really important problems. And the problems you're focused on anesthesia in the brain and how to help people survive and thrive with anesthesia.
Yeah, it's amazing. I think that the HST program just gives you such a different framework for the problems that you see clinically. So I did a PhD in the medical engineering and medical physics program. I'm also a practicing neurosurgical anesthesiologist. And the way that I think about the challenges that my patients face is totally shaped by that training. Really thinking about what is the problem and what are the mechanisms, and not being bound by the field, either anesthesiology or medicine, but thinking even more broadly about what are the tools that we can bring in from neuroscience, from engineering, from psychology, from cognitive neuroscience, and how can we use these things to advance care for our patients. So yes, I mean, obviously we're both a little biased being alums, but it's I'm on the same page with you about what a great program it is.
That's awesome. And then also framing it, you're originally an electrical engineer. You're a scientist by training. So you're not afraid to look at the brain or other human systems in a different way than most physicians are trained.
Absolutely. I still think about the brain as this big circuit, and I really take a very systems, neuroscience, circuit-based approach to things. And I think about the different ways that we can manipulate those circuits by, turning parts of them on and off, just like little light switches that you might have in your house, and how when those wires get frayed or when they sort of get crossed, you can get a lot of problems in the brain. And so seeing this in my clinical practice with my patients, but also in our lab where we do basic science, we bring in 100 or 200 healthy college students every term, and everything that our patients experience in cognitive testing, our students have debugged extensively for class credit a couple of terms earlier.
That's so cool. And the other connection that we have is we both trained or had a connection with Duke. You went to medical school there, and now you're a associate professor there.
Not quite yet, but
okay.
keeping my fingers crossed
Assistant
that the
professor.
APT, APT makes a good choice
Okay.
soon.
Wow.
I'm an assistant professor. I joined the faculty 4 years ago. I was our ACES chief resident the year before that. But yes, I am up for associate. I am hopeful.
Okay. Well, congratulations, and we got our fingers crossed for you. But it's cool. We both study at the same institution, and I'll tell you one of I did a year of surgical training at Duke, and under Dr. Saveston, and one of the things that really hit me hard is when I did my month-long rotation in cardiothoracic surgery. I remember this was literally over 30 years ago, but I remember studying this paper that where they studied patients who had open heart surgery, and 100% of those patients after surgery had cognitive changes, 100%. And I remember thinking, like, wow, and now mind you, with open heart surgery, you put the heart on bypass. That's not every surgery, but I remember thinking, so that was 30 years ago. Has that changed?
It's not every single patient today, but it's still in some places and some types of surgeries, most patients after cardiothoracic surgery. I think the landmark paper for that was Mark Newman's paper in JAMA in the early 2000s. And yes, we've gotten better at perioperative brain health, but in some ways it's almost a little scarier because we've realized it's not just cardiac surgery. It isn't just if you're on bypass. Patients who are undergoing any kind of surgery with the right kind of predisposing factors and intraoperative factors certainly can experience delirium. And so in some ways, maybe the actual percentage, even though the actual percentage has gone down, for cardiac surgery, we've realized this is a much more widespread problem than we did 30 years ago.
Right. And the reason I'm really excited we're talking is because you study delirium postoperatively, and I think, and you may think too, that there's a connection or a similar physiology or pathophysiology between the delirium after surgery and Alzheimer's disease or other neurodegenerative diseases. Is that right?
Yes, absolutely. So the data is pretty telling. So an individual, even cognitively normal individual who goes into surgery and experiences postoperative delirium has an 8 to 12-fold increased risk of a dementia diagnosis after the fact. And the greatest predictive factor for postoperative delirium in an older adult is pre-existing cognitive dysfunction. So the two predict one another. An episode of delirium in someone with mild cognitive impairment will accelerate, or at least is associated with an acceleration in cognitive decline. And so this is a really serious issue and a bit of a chicken and an egg. So we don't know whether we're simply unmasking pre-existing cognitive vulnerabilities. My team has some pretty good evidence to suggest that we are, or whether we are actually causing additional insult, which is definitely possible with delirium, or some combination of both.
Wow. And I think it's probably a combination, but so as an example, from the studies I'm looking at, the biggest risk factor for developing Alzheimer's turns out to be not getting enough deep N3 sleep. And I could see how after surgery that could also affect people's ability to sleep. Have you studied that?
So the closest that we have come with sleep is that in our most recent paper where we looked at heart rate variability and showed that it predicted post-operative delirium. So if you had poor post-operative or pre-operative heart rate variability predicted post-operative delirium. And we collected all of that data during sleep. And so it would beg to reason that if you have poor sleep, that would ramify out into autonomic dysfunction, poor resolution of inflammation, and delirium. And so sleep is one of those things that's really hard because people have so, as you know, this is your area, people have so many reasons why they don't sleep well. And the biggest misconception I come across is people think that anesthesia is a replacement for sleep. And it is not. So people will think that so people will say to me, oh, well, I don't need to sleep tonight. I'm going to be asleep in the operating room all day. And I say, oh, I wish it worked like that, but it doesn't. You need even more sleep to heal. And there's so much good data coming out about how we clear toxins from our brains during sleep as well, especially with the pulsatility of CSF. So yes, anesthesia is not a replacement for sleep, and sleep is very important.
Wow. And you mentioned heart rate variability. It turns out that a healthy heart will have a good amount of heart rate variability. So it could be that what you were looking at was just the healthiness of someone's heart, potentially.
Yeah, so that's part of it for sure. I think that in this study, we didn't want anyone enrolled who had pre-existing heart disease. So that was actually an exclusion criterion, as was beta blocker use. So no arrhythmias, no fast or slow heart rates, no beta blockers. You can't do a study in older adults and eliminate hypertension, for example. But we did get folks who had healthy hearts by and large. And so our hypothesis is that it's actually a vagus nerve connection. So the brain and the heart and the immune system are all connected through that vagus nerve. And that's part of the autonomic nervous system. And so the ability of the heart to adjust its rate in response to breathing is vagus nerve mediated. It's a sign of vagus nerve health. We know that there is the cholinergic anti-inflammatory reflex, in which peripherally the efferent vagus nerve fibers sense that there's a lot of inflammation. They tell the brain, hey, there's a lot of inflammation. And the brain goes back down and signals through the nicotinic acetylcholine receptors, hey, slow down. You've got this infection under control. No need to get excessive inflammation. And so we think that that's neuroprotective in a way, that you need a little bit of inflammation, but you don't want too much inflammation after surgery. You want just enough to heal. And so that was our hypothesis. But sleep comes into this too. And there was definitely a reason why we recorded heart rate variability during sleep, because we felt that it was the best and most representative time of the patient's actual autonomic function at baseline.
Fascinating. And I've worked in the past with other anesthesiologists who've developed vagal nerve stimulators. Have you looked at vagal nerve stimulation?
Yes. So we have done pilot studies with vagus nerve stimulation, not invasively, but transcutaneously. Invasive vagus nerve stimulation is tough because anatomically, the vagus nerve is in that carotid sheath, right? And so in an awake and breathing patient, you really don't want to go sticking near the carotid artery. But there are newer technologies coming out that are transcutaneous through the skin, and those seem to show some promise.
Wow, that's exciting. So let's also talk about anesthesia itself, because, and this dates me a little bit, but, I remember learning that like some of the old inhalational agents like halothane can cause liver problems. First of all, do you still use halothane in your practice?
No, so we do not have halothane in our practice. And like many hospitals, but not all, we've actually even eliminated desflurane here at Duke. It's a good anesthetic in terms of its properties for anesthesia as fast on, fast off, but it is absolutely horrible for the ozone. And so whatever minor incremental benefit it might have with anesthesia does not outweigh the environmental impact. So in terms of inhaled anesthetics, we only have nitrous, of course, and then SIVO and ISO here. And I think that's pretty common.
Got it. And I know this is pretty nerdy, but guess what? We both trained at this HST Harvard MIT program, so we can go there. How much of these inhalational agents, the fluoridated agents, how long do they actually stay in the body, or do we even know?
So the textbook, teaching, I'm a board certified anesthesiologist, so I had to memorize all the stuff for boards. The textbook teaching is that you can have sevoflurane or isoflurane in the system, kind of leaching out of the fatty tissues for about 24 hours. It's not at a high enough concentration that it's going to render the patient unconscious or anything like that. But the teaching that I learned was that it's about 24 hours for those fluorinated agents to get out.
So here's a question I have. So for my patient population who has Alzheimer's or other neurodegenerative diseases, many of some, I'm not going to say all, some of them will have biofilm, they'll have infections, they will have, this is kind of a gross example, but some of them will have parasites in their brain and elsewhere. And we know that within this biologic film, this biofilm, there could be parasites. Some of these parasites will concentrate toxins within themselves, within the organism itself, to use as a weapon against other bugs. I mean, there's this ancient biological warfare that predates humans that we kind of have stepped into. I always wonder, sure, it's not huge amounts, but some of these let's just be upfront. Some of these anesthetic agents are toxins. Could some of these, not just for an hour or 24 hours, could some of these be stored in the brain and other fatty tissues well after, maybe not large amounts, but enough to be important?
Honestly, I don't know. I've never seen any evidence to suggest that they stay longer than 24 hours. There were a lot of studies in the 90s and early 2000s about sevoflurane in kidneys and kidney injury because of excretion. None of that ever actually kind of came to be anything of clinical relevance, even though it was studied for a long time. The other thing is, it's not the only anesthetic we use. We often will use a total intravenous anesthetic with propofol with patients. That's become much more common. And it just depends on the patient and their needs and the type of surgery. But there are many ways to anesthetize a patient.
Oh, no question. And often patients are getting more than one agent at the same time. So
yes, there is then a push toward multimodal anesthesia, particularly for pain control and for nausea, so that you can hit different receptors. In my own practice, I tend to run a pretty clean anesthetic for older adults in sort of a less is more, fewer agents rather than more. It's not like right or wrong in practice. It's just my preference.
Fair enough. And this is a touchy subject, but do you ever worry as an you're a practicing anesthesiologist? They're currently the anesthesiology systems have good traps to capture, but are you worried about your own occupational exposure?
I don't worry about it. I think the proof is in the pudding. I have 4 children, and I had them all while I was practicing, and the first 3 in residency, and the last one as an attending. And they all seem to be all right. So I feel like if there were a toxic exposure, the fetus is the most vulnerable, and the anesthesiologist most likely to let the gas out into the room is probably the most junior one, which I was as a trainee. So I've not seen that. I think that there have been a fair number of studies about occupational exposures. The place that can, or at least used to, be at higher risk were like dentist's offices and places where you would do sedation and you wouldn't have proper scavenging systems. But in modern hospitals, the scavenging systems are quite advanced.
Nice. And along those lines, do you ever recommend before surgery, especially if you have a high-risk patient, maybe senior who you're worried that they don't have a great heart rate variability. What are the things that you do pre-operatively to prepare them for the major stress of surgery?
So we haven't yet gone to the point where we're targeting heart rate variability, but a lot of the things that we recommend will improve heart rate variability. For example, smoking cessation makes a huge difference in improving both heart rate variability and decreasing the risk of pulmonary complications after surgery. Things like getting diabetes under better control, improving nutrition. Many of our patients coming in for surgery aren't eating well and they're malnourished. So it's really important, even if somebody is at a normal or even higher than normal weight, not to assume that they're well nourished, but to really ensure that they're getting the nutrition that they need. Some of our patients, and this gets into another one of our papers, just sort of run themselves ragged before surgery, trying to get everything in order. And that's really detrimental. Taking care of yourself, getting sleep, getting exercise, making sure there's family support, eating well, all those things are so important. And they sound simple until you ask the patients to actually do them in the middle of a stressful time. And in the midst of a stressful time, that stuff's hard for all of us.
So in the real world, so I remember at Duke, obviously a big tobacco producing area. Um, so how would you help a patient preoperatively stop smoking?
So we take this really seriously. So we actually will have a smoking cessation clinic that we can refer patients to. The state of North Carolina has the NC Quit line. I would assume other states have similar things. We'll try things like nicotine replacement with a patch. And also, I think just a lot of, patient-doctor communication, telling patients, hey, this is a kind of pivotal point, right? There is a set time period until you need surgery. There is a clear benefit to quitting smoking. This is an inflection point where you can make a choice just for a short period that will really have a much greater and more immediate return than maybe is obvious from just quitting smoking at a different time. Not that it's ever a bad idea to quit smoking, but having a particular time in mind, a very, objective payoff, I think can kind of help.
Definitely. And then in terms of nutrition, what nutrients are important perioperatively or for the brain for that matter?
So there are sort of the standard things that we check, thiamine levels, folate levels, making sure that there aren't frank deficiencies there. We also will often check a prealbumin and an albumin, which is looking at protein, just sort of looking at how someone's been nourished, over the past couple of weeks, which is your prealbumin, over the past couple of months with your albumin, and seeing whether they're eating enough, basically, and whether they're eating enough of the right things. And so it's not a super fancy, super prescriptive diet. You must have, an egg and toast and a banana every morning for breakfast or something like that. But it is a kind of idea of, okay, you're not getting enough of this, so we're going to try a boost shake or an ensure shake, or we want you to try to get an extra serving of vegetables with dinner every night. Things that are manageable in the course of everyday life.
Awesome. And I think one of the major parts of your research is looking at EEG, non-invasive way to measure the brain. First of all, do you use EEG much intraoperatively?
Yes. So most cases that I do, I use EEG intraoperatively, not a full swim cap of electrodes like we do in the lab, but at least a couple of electrodes as a depth of anesthesia monitor. And this is in part because of the types of surgeries that I'm doing. I tend to do a lot of total intravenous anesthetics, where we use that to make sure that the patient is in a deep enough anesthetic state, but not so deep that we have turned off all brain activity, because we want them to be in sort of that Goldilocks place of not too much, not too little.
Certainly. And what I'm excited, I'm starting to use this in one of my clinics, is an EEG test that basically with 30 minutes, I can actually image parts of the brain. And this sounds really weird, but even measure correlations with amyloid and tau and other degenerative proteins in the brain. Are you doing something similar?
So we aren't measuring that, although I would love to talk more with you about that offline. We are, so in the operating room, it's very simple. It's just depth of anesthesia, because nobody wants to be awake during anesthesia, and we certainly don't want them to be awake during anesthesia. In the lab and in sort of with our patients who come in for cognitive testing, we use the EEG in an evoked way. So they are doing something and it is inducing some change in their brain waves. And we use that change in brain waves as a way to assay kind of their functional health. So, for example, one of the simplest things one can do to make a change in their brainwaves is to open and close their eyes. In fact, this is what Berger observed in the 1930s. And so you can close your eyes and you get these big, 10 hertz, so 10 cycles per second waves. And then when you open your eyes, they should essentially go away.
Are those called alpha waves?
Those are called alpha waves. Yes,
Okay.
exactly.
Okay.
And so those alpha waves, that alpha suppression with eye opening is canonical. You'll see it in infants. You should see it throughout the entire lifespan. But we know that in neurocognitive disease, that suppression is not as pronounced. And so we actually had a study of all normal, cognitively normal older adults undergoing major surgery. We measured the extent to which that alpha wave was suppressed with eye opening, and we compared it to post-operative cognitive outcomes. And we found that those before surgery who didn't suppress alpha as much went on to be at higher risk for post-operative attentional issues. And so it does seem that even these simple evoked waves can show a vulnerability that's compensated until a stress occurs.
Interesting. So it sounds like you're measuring alpha waves both intraoperative but also preoperative, or what do you normally do?
So in our research studies, we do them preoperatively. With these monitors, you just put them on the patient's forehead as you're drifting them off to sleep. You can put it on before they go to sleep. You can put it on after they go to sleep. Personally, I think there's some value in putting it on before they go to sleep because then you have a baseline for the patient. Not that you'd expect anyone to look anesthetized before you give them any medication. But it's practically, 6 of one, half dozen of the other. So it's not hard to get that data before they're asleep.
Got it. And one of the interesting things I found is variability. As you mentioned, checking someone preoperatively, but obviously surgery, anesthesia is a stressful event for people. Tell me about the research you've been doing on stressing the brain.
Right. So I tend to think of surgery in anesthesia as a stress test for the brain. And there's a few reasons for that. The first is that it's just an emotionally stressful event in general. Nobody actually chooses to have me as their doctor. I mean, if they have to have surgery, they might request me as an anesthesiologist, but nobody is choosing to have neurosurgery. Nobody wants to need surgery. And so that's stressful in itself, and it's a disruption to life. On top of that, there's a lot of physiological stress with surgery. And it's not just the surgery itself. It's leading up to it. People don't sleep well before surgery. Often they get up at 1 a.m. to drive 4 hours to our hospital to check in at 5:30 or something. No, seriously, I see.
It hasn't changed yet.
It hasn't changed. I see this every day. And then the other part of it is, even if they do, say, get a hotel or live in town, they're nervous, so they aren't sleeping well. So that's one thing that our patients are contending with. The next thing is that we have patients avoid eating before surgery. And so that's important because obviously we don't want them to aspirate and get an aspiration pneumonia. It's really important, but that's stressful on the system too. And then you have surgery where you have an injury in that incision and you have to heal from it and there's inflammation. So that is hard. And then there's being in an unfamiliar place, the hospital, and being woken up for checks, not sleeping well here, and all the stress that goes into that. And so this is a really hard time on many levels for these patients. And so it's not surprising that folks who are very well compensated in everyday life, who have some neurocognitive vulnerability, but it's not showing up in any way, that those patients can have it kind of come out in that, biologically, emotionally, neurologically stressful situation.
Wow. So we talked about EEG. I think didn't in some of your research you use functional MRIs too?
Yeah, so that's our new study, Charmed Cognitive Health, Attentional Resilience, and Effects on Delirium. And so, yes, I think it's really important to look at the neural circuits and the integrity of the brain tissue itself in our patients. And so that study is ongoing, and we're about a third of the way through it. So hopefully we'll have those results out soon.
Nice. Okay. So, what advice do you have to someone who's potentially needs surgery to get ready for it? I mean, of course, it's going to be a stressful event, but are there a series of just general advice that you give people apart from stopping smoking, making sure your nutrition is adequate?
Some of the things that I think people forget are the things that you think about. Like I said, I have 4 children. When you're like packing your hospital bag. Okay, so when you're packing your hospital bag, not to have a baby, but to have surgery, I think it's really important to make sure you have your glasses, that if you have hearing aids, you have your hearing aids, that if you are somebody who is sensitive to noise and light, it's absolutely fine to bring one of those eye masks and have that to help you sleep better in the hospital. Things to help you sort of orient yourself back to where you are. It's hard to be in an unfamiliar place to begin with after surgery. It's really hard if you can't see and can't hear. So those things are important. I think talking with families. In our most recent study that's, I think, coming out next month, we talked with patients about what is most on your mind before surgery. And so many patients are concerned about relationships and worried about being a burden on their families. And I would really encourage older adults not to worry about burdening adult children or friends or spouses or loved ones. You need someone to come and stay with you in the hospital. If that thought even crosses your mind, have them stay. It makes a really big difference having someone who is there to advocate for you, to help you get the things that you need, even if they're simple things like pain medicine or a cup of water. So that's important. I feel like a lot of people are worried, at least based on our distress study that's coming out, about all the things that they have to do before surgery. And I would suggest that people give themselves a little bit of grace and delegate some of these things, and don't run yourself ragged before surgery. Don't, get 2, 3, 4 hours of sleep because you're up late trying to get everything in order. Really hand things off as much as you can. And don't feel bad taking that time to focus on yourself before surgery.
The next question, and this thing's, I'm going back to when I was an intern at Duke, and I got a call one it was like at 1 or 2 in the morning that there's they're doing construction.
Oh my gosh.
I wanted the floor. So you have patients who are post-operative from open heart surgery, and so they wanted me, the intern, to tell them to stop, which I did, um, but but here's my question: what are some things that they to help patients sleep after major surgery, but besides eliminating interruptions and things like that? And what other tips do you have?
I think that there's been a lot of talk about, melatonin or Seroquel or things like that. If a patient needs it, if they take it at home, that's one thing. I think that that's a place that we need to be careful. And albeit it's not my area of expertise, but I think that we can go a long way simply with kind of more conservative measures, things like earplugs, eye shields, trying to minimize unnecessary disruptions, treating pain appropriately. And so one thing that I tell my patients is don't let your pain get to a 10 before you ask for pain medication. If it's 9 or 10 o'clock at night and it's been ramping up, get that pain under control before you go to sleep. Otherwise, you won't sleep that night. One of the things that we can do as anesthesiologists is that we can do regional pain blocks for a lot of our procedures or epidurals. And those help patients so much because they aren't having to wake up every 4 hours to request pain medicine. And so I would say that if you can do that, it really helps. Now, the construction, I don't know, I feel like every academic hospital is always having some kind of construction. And if it's not at the hospital, it's across the street or in the campus. And of course, if you're a trauma center like we are, you have a helicopter pad and the helicopter has to come in. And you can't tell the helicopter, no, you aren't allowed to land between these hours. Our patients need to sleep, right? That's sort of that's the whole purpose. So
Wow.
there's always problems.
Amazing. So if we could shift gears here for a minute and talk about your original background is electrical engineering, and the brain is an electrical organ, but it's super complex. So how do you tackle the brain in all your studies and just thinking about it?
Right. So it is super complex. And there are a few things that I realize, I don't know, maybe it's reflecting and getting older, that I will never even begin to understand in my lifetime. And it would take 5 lifetimes, 6 lifetimes to ever get to any kind of depth. And I think the brain is one of those things. But what I do think about is simply, carving out a piece of it. And so carving out this idea of what does it mean to be attentive and attend to something. And so we really focus a lot on attention, attentional circuits, attentional control, executive control. As you know, deficits in executive control are one of the first signs of neurocognitive decline in Alzheimer's disease. And so I feel like you're getting close to kind of cognitive ground zero, not biological, because we know that the neurobiological changes in Alzheimer's occur well before any symptoms, but sort of the cognitive manifestations. And attentional deficits are a key sign in delirium. So it's attention and arousal that are disrupted in delirium. And as an anesthesiologist, they're also the main thing that I worry about. Because if a patient can attend to surgery, by definition, they are not anesthetized.
But what's also interesting is anatomically. I mean, you mentioned executive function. We know that a lot of executive functions in the frontal lobe, but there are other functions of the brain that are distributed. It's not just the frontal lobe; it's distributed throughout the brain. It's a fascinating architecture. But how? I mean, right now, I guess recently you've been doing studies on functional MRI, which I guess is a functional study. It's not an electrical study. Is that true, or?
Yes, that's true. And that's the main shortcoming with fMRI, right? You're looking at patterns of we also look at structural things and we look at DTI, so we look at connectivity. But getting in the functional part of it, you're looking at essentially blood flow, right? Seeing where blood is flowing in the brain and how that blood flow is correlated between different areas. But you're not doing it in real time. With EEG, we are recording on the time scale that those neurons are firing, but we're only doing it from the surface of the brain. And so you can put the two together. It's very technically challenging, but I think that helps. As a neurosurgical anesthesiologist, sometimes we do anesthetize for cases where we record directly from the brain. The challenge with that is you're never going to put electrodes in a healthy human brain. You're always putting them in for a serious pathology. And so that data is super, super useful and really important, but it is also something that needs to be interpreted in light of the fact that it's not being collected simply for science or research.
Sure. And going back to the example you gave intraoperatively, you mentioned alpha waves. I thought alpha waves were mainly produced in the back of the brain, but I guess you're monitoring in the front. Am I missing something, or is this electrical activity spread throughout? Depending, even it doesn't matter where it's coming from.
You're right, Dr. Josh. So the canonical teaching, right, with alpha waves is that it's posterior alpha. And that's because in the occipital cortex, that's where you have your primary visual area. And so in the back of the brain, that's where we see that big suppression in alpha. Interestingly, though, we found that the alpha suppression, at least in our population and in our BJA paper, doesn't matter where in the brain you record it. So maybe the total amplitudes are all shorter, but if you're looking at a percentage change, you can record it from the front and predict it just as well as if you were in the back.
Wow. And so, and do you think that's because these signals are conducted throughout the whole brain, or?
I think so. I think that if you're hypothesizing that there's this corticothalamic circuit, yes, you're going to see it most prominently in the occipital cortex, but those projections are going all over the brain. And even in some of our work where we're looking at attentiveness more generally, where you're not paying attention, say, to something in particular, but just general attentiveness, which is kind of more what I'm interested in as an anesthesiologist, you'll see this globally. Much of our work in attention has focused on visual attention because it's such an accessible area, and visual perception is such an important part of how we interact with the world around us. But it's not the only thing that we pay attention to. It's not our only sensation. And so I think that there's good evidence to suggest that alpha can direct attention toward many things, not simply visual attention. It's just that visual attention is what we are most accustomed to studying.
Fair enough. And in terms of functional studies, do you have much experience using PET scans of the brain?
So I haven't gotten into PET scans much. Some of my collaborators have, but PET scans can be really important for Alzheimer's.
And then you're mentioning attention, and I'm thinking some of my patients in the past who've had ADHD, when I look at their PET scans, they'll have defects in their anterior cingulate, etc. Anatomically, I mean, I know it's more than one area, but when you think of attention, what parts of the brain do you normally think of?
So we tend to think of the dorsal attention network, but the anterior cingulate is somewhere that we certainly think about when we're seeding images. And the thing that you bring up that I think is really important is the idea that older adults and that many older adults may very well have undiagnosed ADHD. There is a fairly high genetic correlation of ADHD within families. And if you think about the rates of ADHD diagnosis today, maybe, 7%, let's say 10%, I don't know, it keeps going up. And then you think about what the rates were 50 years ago, and the fact that this is almost always diagnosed in children. How many older individuals are there who today, if you went back to their classroom as it was when they were in school, would meet that criteria and that diagnosis? So it's interesting. One of the things that one of the neuropsychologists I work with has us ask our patients is the idea of a couple of things. What is the latest in the day that you would drink a cup of coffee? Okay. So most people will say something like 3 o'clock if they go to bed at 9 or 10, maybe 4 o'clock if they go to bed at 11 or 12. If you have somebody who says, oh, I'll drink coffee at 10 p.m., that's a tip off. If you have somebody who says, I have a backward reaction to coffee, coffee makes me more tired, that he says in his kind of, geriatric neuropsychology practice and 30 years of experience, to him, that's a what do we call it? Like country doctor type takeoff.
Sure.
to undiagnosed ADHD. And so I just find that interesting. We haven't analyzed that data yet, but
it is fascinating. And I've seen, coffee is a stimulant. The caffeine is a stimulant. You got theobromines and other stimulants inside it. And if you have a patient who has low levels of dopamine in the brain, it makes sense that they're using the caffeine to function better. So in terms of chemicals, are there any biomarkers that you currently use or if you've used in the past to look at brain function?
So there are a whole host of new Alzheimer's biomarkers coming out. So a lot of these phosphorylated tau markers, and they seem to show a lot of promise. And so I think that this is an area that is going to be really explosive for our field in the future. Perioperatively, we tend to look at things that we expect to change around the time of surgery. So biomarkers of inflammation and of neuroinflammation, of blood-brain barrier breakdown. But for the general population, in terms of thinking about a baseline risk, I think that these phosphorylated tau markers will be very useful. The only kind of caveats I'd give are they need to be interpreted with caution if somebody has, say, an issue with clearing them. So like decreased kidney function, or if they have an elevated BMI or a very low BMI. So thinking about the whole patient in interpreting these, but more broadly, they seem to be very promising.
Wow, that's so exciting. Going back to the electrical model of the brain, I mean, the most extreme of this is you see a patient with seizures where you've got a electrical circuit that you can't break. How common do you see seizures intraoperatively? And I guess along those lines is, could it be that there's some people without frank seizures who are having loops of electrical current in the brain that just are not good?
So I don't know if I'm a good person to ask this question
Okay.
because I'm a neurosurgical anesthesiologist. So
Okay.
I probably see, I would say, 20 times as many seizures as the average
Okay.
anesthesiologist, maybe 100 times as many seizures,
Wow.
because, some of my patients are having surgery because they have intractable seizures, right? And so we sort of expect seizure-like activity, or we're resecting a brain tumor that is causing seizures. And as we're mapping, you can induce a seizure. So I feel like I see a fair number of intraoperative seizures. And in fact, I give lectures on this topic to the Society for Neuroscience and Anesthesia and Critical Care. But truthfully, seizures are very, very rare in the general population with surgery, because propofol, which most anesthetics include, is a strong anti-epileptic. So where you can actually see it and you need to be worried in someone who does have a seizure disorder is not during the surgery, but after the surgery. So it's really important to make sure that they've stayed on their baseline regimen. Otherwise, the combination of coming off of propofol and of missing a dose can precipitate a seizure. And so we're always very cautious about making sure those who need anti-epileptic medications to keep their seizures in check, making sure they stay on their regimen.
From what you know about the brain structure, what causes it to be resilient or respond well to stress, whether it's operative stress or whatever the stress is?
So I think that we know that with aging, you have cortical atrophy in the brain. And sometimes it's part of normal aging, sometimes it's actually neuropathological. And so sort of having a thicker cortex and sort of more robust parenchyma matters. I think strong connections within the brain matter. And those are critical. There's been an increasing appreciation of the role of kind of subclinical neurovascular disease. And so the same things that we tell people about keeping their heart healthy, keeping their blood pressure in check, things like that, it actually really matters for the brain too, maybe more for the brain even than for the heart, even though a heart attack is much more of a feared and catastrophic outcome. I think day to day, there's a lot of wear and tear on the brain when you have cerebrovascular and cardiovascular health concerns.
Wow. And that's what I'm finding with my Alzheimer's or other dementia patients, that they're between 30 and 200 root causes. It's just like the brain is extremely complex. Many of these different systems can also have issues. And I understand, as an anesthesiologist, you're focused on attention and the cardiovascular system. My question is, how, when we're dealing with these different diseases that are super complicated, just from taking a step back as kind of from an engineering standpoint, how do you put all these different systems together and try to fix things?
It's a really, really hard question.
Yeah,
Again, is this probably something that'll take a couple of lifetimes to totally fix?
sure.
But there are some things that I think are sort of I still think there's some low-hanging fruit in this field.
Okay.
There are still a few things that you can do that make a big difference for patients. And cardiovascular health is a big part of it. Getting diabetes in check is a big part of it. And I know maybe it's because I'm, still in tobacco country, but smoking cessation is a big part of it. I think that excessive alcohol use, it can be a part of it. The data is still, I think, sort of evolving for kind of moderate or low levels of alcohol use, but excessive alcohol use, we know that's not good for the brain.
Right.
So those sorts of
We know alcohol is a neurotoxin. It also interrupts sleep.
it does.
It prevents the deep sleep, the N3 sleep. Um, do, do you ever get sleep studies on your patients before surgery?
So patients who have severe untreated sleep apnea or who score on our screeners in a way to suggest that they have severe untreated sleep apnea, that's certainly something that they could detect in the pre-anesthesia and surgery screening clinic and refer patients for. Um, there are a lot of patients who, as I'm waking them up from anesthesia, they said they don't have any sleep apnea, but I realized like, oh, I'm going to mention this because maybe there is an undiagnosed sleep apnea there. I think that can make a big difference. And you're right. There are a lot of people who will drink alcohol in order to go to sleep, to have a nightcap. And but it also typically means that they're going to wake up a couple hours later and they have this fragmented and disrupted sleep. So like you said, they don't get into a deep sleep. And it's a hard kind of patient doctor discussion to have because there's a lot of people who've been doing this for 50 years.
Right. I mean, there are people out there with anxiety for many different reasons, and it makes sense. What can you do for anxiety? You can take something like alcohol that increases your GABA neurotransmitters, which will then bring the electricity in the brain down. So they're basically treating. They're trying to treat an underlying condition. There's nothing wrong with that. It's just there are better ways to treat anxiety.
And we've definitely come a long way in our treatment for mental health disorders. And that's something I often sort of reflect on, that like over the course of my patient's lifetime, especially my older adult patients, like when they were in younger adults or even in middle age, they didn't even have SSRIs widely available, right, until the late 80s. And so you start to like put this in context, I think of all that a brain can go through over the course of a lifetime. And I'm just sort of in awe of it at times.
Wow, that's amazing. Let's talk about the future, and it's cool. You get to participate in neurosurgery cases, and I mean, just watching how that whole field is advancing. And you mentioned, normally we can't put electrodes into human brains. But based on what you're seeing in the operating room and at conferences and being an NIH funded researcher in this whole field, what gives you optimism, and what areas of brain research do you think, looking back 5 years from now, will seem the most important changes?
I think that we are making a lot of good headway in understanding the aging brain. So I think that there had been a little bit of neglect toward it and sort of a hyper focus on a few specific conditions. And now I think that we're starting to, as a field, get this idea of, okay, this is a much more complex and multimodal issue than we thought. So I think that is a really interesting and promising trajectory. I think that there has been a lot more interest in the autonomic nervous system and on the effects of kind of brain fog. And part of that is, unfortunately, because of this like post-COVID, long COVID syndrome. And so I think, are getting a better appreciation of the connections between the brain and the body, and starting to not have as isolated of an organ system approach to medicine, but really thinking about the integration across organ systems. This is a hard thing to overcome. You know it as a doctor as well, because we have this very, organ system based medical education in this country, yet we treat patients across all of their organ systems, and all those organ systems talk to each other. And so I think it is an evolution in our thinking as physicians that will really benefit our patients. The other thing that I find just very promising is really a focus on more of what matters to patients and a personalized medicine. Now, I know we've been talking about personalized medicine for 30 years, and a lot of it was about like, oh, this is your genome and you will have, a drug that, is custom tailored for you. And there have been a few cases with rare genetic disorders where we have, custom tailored drugs. But I think that where it's actually going is going to be a harder look at each patient kind of as an individual. And some of this might be powered by AI as well, because it lets us take in and summarize so much more information to kind of distill things to root causes. But I'm very hopeful that we will be able to have a more holistic view of our patients, and that will allow for much more tailored and personalized care.
Yeah, that's an exciting vision, and yeah, you're right. We've been talking about personalized medicine forever, but when I'm doing genetic analysis on some of my patients, I'm coming up with rare genes that affect how much anesthesia they should be given, for example. So, but I take it that's not something you don't normally look at the genetics of your patients before you go to the OR, or do you?
There's one group of patients that I'm very concerned about their genetics. Those are individuals who have a familial mutation in the reniodine receptor that leads to malignant hyperthermia. So we do pay a lot of attention to that. I always ask patients if they have a first-degree relative who has red hair, because we know that increases anesthetic needs and demands. So yes, there are definitely things that kind of titrate. There's been a fair amount of research looking at genetic variants in the opioid receptor, because there are some people who get very sick to their stomach with opioids. There are some people who even have a kind of paradoxical reaction, who find opioids almost stimulating. And so understanding how opioids work in a particular patient are very important, because for years they've been sort of the kind of default or first line treatment for post-operative pain. And we're moving away from that, obviously, with all of the negative effects of opioids we've seen. But understanding which patients will really benefit from them short term, get off of them quickly, and go on and live their lives, versus those who will have issues is critically important. And it's an area I would love to see us be able to tailor more effectively.
That's amazing. Is there any question I forgot to ask you that should have?
Oh, I don't know. We've had such a just rich and wide-ranging discussion. It's been such a joy talking with you about all of these topics and thinking about how we can make medicine and care better for our older patients.
Yeah, that's the vision, and it's amazing the parallel between delirium you see in the operating room around there and Alzheimer's in general, the stress. If people want to reach out to you, is that okay? And how can they find you?
So they can find me on my lab website. It is ackerlab.com. So ACKERLAB.com. And then they can email ackerlab info. Emailing me personally is often difficult, because I feel like I get more emails. And when I'm in the operating room, I don't check my email. I just
Good. I'm glad you don't.
On my patients. I don't. But it means that there are a number of days in any given week, in any given month, where I am not checking email, because I believe my patients deserve all of my attention on those days. And so, but definitely, folks can look at our lab website. They can follow us. They can look at us up on LinkedIn. They can follow our work. And we would be honored to share what we're finding with us.
Awesome. That's awesome. Are you also on social media?
So just LinkedIn.
Okay.
I try to limit my time on social media.
Good.
I think it can kind of become a time suck. But I definitely like sharing the work that my team is doing, the insights that we're finding in this exciting field, and staying connected with others who are doing similar work.
Wow. Dr. Leah, thank you so much for meeting with me today and sharing your wisdom, your scientific and clinical experience in this really important field of the brain.
Thank you so much, Dr. Josh. It's been a pleasure.